Okay, everybody, warm welcome and good afternoon. My name is Kathleen Donovan, and I have the pleasure of working at the Arlington Public Schools Special Education Parent Resource Center, often called the PRC. I'm joined today by my colleague Emma Pearl Sanchez, who I'll introduce in a moment to greet everyone in Spanish. We are generating some Spanish subtitles, and if you'd like to listen along in a different language, we didn't have any language requests, but just put a note in the chat and we'll tell you how you can do that. A little bit about the Parent Resource Center. We sit within the Office of Special Education in Arlington Public Schools. So we primarily work with families who have students receiving special education services or who have a Section 504 or another disability, but we welcome all families to access our supports. We offer parent learning opportunities like this today that we're excited to welcome both staff and parents to. We have a lending library and an informational website. We also offer one-to-one family consultations if you'd like to learn more about how you can support your child's learning or connect with community resources. I'll go ahead and put some notes in the chat so you know how to reach us. But thank you for joining us today. I'm very excited to hear about crisis services in our community. And as I've tried to share in our messaging, I think I'm especially grateful to know about this outside of a crisis. It's hard to know in the moment, sometimes how to access the appropriate services and who to call. So we have a wonderful team today that's joined us to help us know how to navigate the wide variety of services and supports that are existing. If you have any questions, please drop them in the chat and we'll plan to turn the recording off toward the end of the session to answer questions. Feel free to put questions in the chat and the team will be monitoring the questions if you like. We will ask everyone, if you're not speaking, just for clarity, if you could keep your Zoom settings on mute, that will help us be sure that we are not capturing other sound that we're not, that might interfere. Okay, so I'm going to then go ahead and just turn to Laura Clark. Laura, thank you so much for joining us today.
Good afternoon. My name is Laura Clark, and I am the Senior Director at PRS Crisis Link. We are the Regional Crisis Call Center. I'm not quite sure how to get the slides to advance, so somebody can advance it for me. The Regional Crisis Call Center, there it is essentially a hub of information that connects several different phone numbers across the region to help people differentiate between services, but also help to de-escalate and answer questions earlier before a crisis might occur. The Regional Crisis Call Center is really designed to integrate a long-standing phone number, which is the Crisis Link hotline and the National Suicide Prevention Lifeline. And with an effort to provide emotional support and information, help direct people to other additional services, to do conversations about how to help others, and then ultimately make referrals. The Regional Crisis Call Center is staffed 24/7. We never close. And we have a wide variety of people answering the phone to help support members in our community. We have paraprofessionals answering on the front line and then clinicians on the back end helping support individuals who might be experiencing a more acute crisis. So the great thing about the Regional Crisis Call Center is that it's always open. There's no business hours, and you can connect with someone immediately who can help discern what other services you might need to connect to if you're not sure. It's a lot of content, but ultimately it's designed to hopefully support people at all levels of crisis so that you don't have to keep calling lots of different numbers. So you go to the next slide. My screen just won't pop up. So to kind of talk a little bit about what happens when you dial the Regional Crisis Call Center. We have a lot of different access points coming in. So lots of different phone lines coming in, but the same people generally answering all of those things. So if you've heard about 988, the National Suicide Prevention Lifeline, that's one access point that we answer. We also answer the local numbers that you'll see advertised everywhere locally. It's a 703 number. And essentially what happens is we look at situations in kind of 4 different levels. Most calls that when you reach out to us are resolved with us in our call center. We provide emotional support. We walk through risk assessment. We help you make decisions and empower you to make decisions that work for you and your family. And if another service is needed, what we would do is called a warm transfer. which means we don't have you hang up and dial another phone number. We'll actually call that number for you and connect you warmly so that you don't have to re-explain everything to that other group that you might need help from. And most people, that's when they call 988 or our local number, that's what they experience. For some people who have more complex challenges, maybe a behavioral health need that isn't necessarily easily understood what services should be next, we can refer people into what's called care navigation. So an individual that is walking with you and your family, gathering lots of information to help decide or determine what referral might be needed for you. So that, if you Google getting behavioral health care, it can be quite overwhelming, especially when you're in crisis. So the care navigation function is really able to help sit with you, talk with you about what your unique needs are and get you connected to those different services. In some cases, if the situation is more urgent, we can refer you, which our partners are here today to talk more about, to mobile crisis. And I won't talk about that because they'll explain that in more detail. But mobile crisis is something that is available to everyone in the community, and we might refer you to that resource so that you have immediate response. And then finally, if there's an emergency, a life-threatening situation, we might refer you to a public safety answering point or a 911 center to get more urgent care. That's a really rare situation, and usually the person's in immediate danger. But that's kind of the different ways the calls will get resolved. Next slide, please. Just to provide a little bit of perspective about how 988 fits into that, because there's a lot. I'm missing a slide in there. I think we skipped one, but I just wanted to briefly touch on 988 because it's something that is really crucial to understand. If we could just back one more. 988 is something that's being advertised, but it has a lot of limitations. It's a National Suicide Prevention Lifeline, so you've probably seen it in various different places. It launched technically in July, but I just wanted to make sure that you all understood that when you dial 988, it's dependent on your phone number who answers it. So if you have a number that's out of our region, which region 2 is that little tiny orange space at the top of the Virginia map, you might not get PRS Crisis Link, which means you might not get a local call center because it's a network of over 200 centers, again, based on your phone number. So in order to access local resources, we really want you to call PRS Crisis Link, which is kind of further in the presentation, the number, so that you have access to these local resources to ensure that everything that I just described, care navigation, mobile, all of those resources are available to you regardless of your phone number. So that we just kind of give you a little education about the difference between the two different phone numbers. While PRS might answer both of them, in some cases it may not. So the local number is the preferred number. So I'll go ahead and pass it off to our next presenter because they'll talk more about the mobile responses that you might be able to receive from the Regional Crisis Call Center.
Thank you, Laura. So I'm Kara Shevlin. I'm the director for CR2. So I'm going to start by talking a little bit about mobile crisis services. And for time's sake, I'm going to talk about mobile crisis and community stabilization, both of which are services that are provided by CR2 and REACH. So I'll give an overview of that, and then Lee will give some more specific information about REACH. So just to start, just an overview of the target populations that CR2 and REACH are supporting. We are all cross-trained to support the community as a whole. Meaning that for somebody with a behavioral health diagnosis or for somebody with an intellectual or developmental disability diagnosis, we're all able to support. Just to share that CR2's subspecialty is behavioral health, while REACH's subspecialty is intellectual and developmental disabilities, and these will be your primary resources for each of those populations. You can go to the next slide. So I'll start by giving a little bit of background about the CR2 program. So we are a mobile crisis response program. We've been around since 2014, originally just serving youth. We've gone through several expansions, which has brought us to our lifespan model. So we now serve anyone and everyone of all ages who's struggling with a mental health crisis. When we talk about a mental health crisis for the purpose of mobile crisis services, we're talking about an individual who is struggling with mental health symptoms to such an extent that they're at risk for decompensating further and potentially needing more care, such as hospitalization, unless they receive some sort of intervention between then. And for the purpose of this presentation, we are hoping to be that intervention to keep the person safe and stable in the community setting. So we serve the entire Nova region, Arlington, Alexandria, Prince William, Fairfax, and Loudoun counties. We provide a rapid mobile response. So I like to describe our team as first responders for mental health. That's the best way to kind of picture what our staff do. We are here to support clients that are struggling with mental health symptoms, and we respond directly to that person, meeting them both physically and mentally where they are at. So we arrive to them in the community setting within 60 minutes of a call to our crisis line to help them through their current crisis. We focus on preventing unnecessary hospitalizations by safely supporting people in the community whenever possible. Again, we are 24/7, 365. Our program is short-term and intensive. So under this program, we're not doing things like outpatient or substance use treatment or unpacking traumas that really need more attention. We're focused on the here and now. How can we help you and your family right now? So we're looking at safety planning, initial assessments, offering psychiatric services is something that we offer through the CR2 program. We have a psychiatric nurse practitioner on staff with us who is available if somebody wants, and is not a required part of our program, to have a psychiatric evaluation if they can't meet with their own psychiatrist during the time of a crisis, or perhaps they've never had one and they're interested in an evaluation. It's a great tool to be able to gather more information for yourselves, for your family, to make informed decisions and know about all the options that are available to you. That's offered virtually. We also have bilingual counselors, which allows us to access the very diverse population of the Nova region. We have many Spanish speakers, Twi speakers, Hindi speakers, Arabic speakers. We also use a language line, which is 24/7, which can assist us in connecting to all of our community members. We also focus on care coordination with any ongoing providers that somebody may currently have in place so that we can make sure we're getting that person the best possible care and coordinating all of their services. And one of the most important things about our program is that we are grant funded. So there is zero cost for this service. It is accessible to all of our community members that live within our region. And it does not matter whether they have Medicaid, private insurance, no insurance. We are happy to help anyone and everyone. We also do not ask about legal status. So if somebody is not a US citizen, that is not a question we are going to ask. They don't have to be worried about accessing our services for fear of those questions. We are here to help everyone. Next slide, please. So what actual services do we provide? And so these services on this slide and the following slide that I'm going to discuss are services that both CR2 and REACH offers. The first is our mobile crisis response service. And Lee will talk a little bit more about how this might be different a little bit for REACH, but for CR2, I want you to remember that mobile crisis is what you want to think of as our front door. That's how you're going to access all the services that you may need in regards to crisis services. So in these scenarios, we support individuals through mobile crisis that are actively struggling with mental health symptoms. Remember that active crisis that I talked about a few slides back. And we are arriving directly to this person to provide them with support within 60 minutes of a call to our crisis line. This service is focusing on the here and now, safety planning, making sure that the situation is safe, teaching coping skills, relaxation techniques, mindfulness, things that can help somebody right here and now to stay safe and divert from possibly needing a higher level of care like a hospital. And our service is short-term and intensive. So mobile crisis focuses on up to 3 days of service. In theory, this person could receive services from us following one mobilization. We would spend however long it took with that person, 2 hours, 3 hours, 4 hours. At the end of that service, we may never physically see them again, which is a good thing, right? For us, that means they were stable at the end of our service and we connected them with resources. and they were no longer in need of crisis services. We'll schedule check-in calls with them to make sure they're still doing well, offer additional mobilizations and additional resources, but that may be the only service that they get from us, which for them is a good thing. You can go to the next slide. Alternatively, at the end of day 3, next slide, please. Oh, a few too many.
There we go.
Nope, one more. Yep. So after day 3, they may still be experiencing a crisis and need more support than just the initial mobile crisis can offer. And for that, we offer community stabilization, as does REACH. Community stabilization is meant to be a bridge service. So think of it as a stepping stone from a more intensive service like mobile crisis to a long-term based community provider such as outpatient, support groups, things of that nature. So again, community stabilization is meant to be that bridge. We're still focusing on the here and the now of the supports, offering education, identifying natural resources and connecting them to long-term care. One of the major differences with community stabilization is how it's structured, in that this is a little bit more scheduled. So rather than a right here, right now response within 60 minutes, these appointments would be scheduled. We focus on the initial week of services in order to help somebody stabilize. Although we can go past that if there is still an active crisis at the end of week 1, we tend to find that by the initial week, the crisis has kind of diminished, not that the symptoms may be completely gone or the need is gone, but there's no active crisis happening at that time. And we have connected them with some long-term providers. Alternatively, for REACH, which Liv can speak to, they offer a bit longer of an initial community stabilization period because of the population and how long it tends to take to stabilize in those scenarios. I'll talk a little bit about how to make a referral to us, and then I'll let Liv talk a little bit more about REACH services. So for CR2 services, you can access our line directly. All of our contact information for CrisisLink, CR2, and REACH is all at the end of this presentation. You can contact our line directly. Anyone and everyone is welcome to call in. Our clinicians manage our crisis line, so you will always get a clinician on the other end that is ready to assist you. They'll start by gathering background demographic information, and then we'll talk about the presenting problem and how we can help support the person that is in need. If you're not sure whether we're the most appropriate service for you, we always say call instead of don't call, because even if we are not the right door for you, we are not going to let you leave with nothing. So even if it is not us, we're going to help connect you with the most appropriate service to help support that person's mental health. And so I will pass it to Liv to talk a little bit more about their crisis services.
Hi, good afternoon, everyone. Thank you so much, Kara, for that introduction. My name is Liv O'Neill. I am the program director for REACH Services here in Northern Virginia. Again, Kara gave a wonderful overview of mobile crisis as well as community stabilization. Both of those services are provided by REACH. I will discuss some of the additional REACH services that we provide outside of what CR2 provides. So similar to CR2, we operate a regional crisis and referral line. It's highlighted here in red, the 855-897-8278. This serves as our single point of entry into our program. We receive several calls throughout the year, a majority of which we are able to provide phone consultation to an individual, a family member, a support system, or another community provider who is working with an individual with a developmental disability, and we're able to provide that phone de-escalation and phone support to them. We are also using this line as a referral line, so individuals can call themselves to place a referral, or any other community member can. This line also serves as the initial point to request a mobile crisis response. We too have a 60-minute or less response time, similar to CR2. We have staff who are strategically located throughout Northern Virginia in order to meet this response time. I wanted to also talk a little bit about our REACH prevention services. So every individual who is referred and consents for our service is enrolled into REACH prevention. They will be assigned a REACH coordinator who will follow their case from the moment of contact to when the crisis itself is resolved. We define a crisis as when an individual or their support system do not have the tools in order to support them through that crisis. We define a crisis being resolved when that individual and their support team feel like they have a reasonable amount of tools and resources that they can use to help de-escalate the crisis without the need of additional support. It is extremely easy to reopen an individual back into REACH crisis services. All you would need to do is call our number and ask for support. Our mission is to educate. So part of what we do is we talk with providers, family, healthcare systems, mental health professionals, law enforcement, and individuals within their natural support system to educate them about what does it mean to have a developmental disability, how to support somebody who has a developmental disability, especially when we're talking to maybe mental health professionals or law enforcement. We may talk about how various mental health diagnoses may present in an individual with a developmental disability. We do clinical trainings on a monthly basis from the months of September to June. I believe our next topic is on anxiety, but we provide community monthly trainings to our stakeholder group and constantly receiving feedback for what future topics may be helpful. We also provide assessments. So we assess crisis situations and provide interventions and strategies to help mitigate risk. We assess for mental health symptoms. What is the behavioral function of the crisis that's going on right now? In addition, of course, we provide those crisis services that Kara already explained. And then we work on habilitation. We talk about teaching effective coping skills to help resolve a crisis, to develop stress tolerance, and also to develop functional skills for increased independence. Next slide. One additional service that we provide is we operate crisis therapeutic homes. We operate 2 here in Northern Virginia. One serves the adult population, 18 and older, and one serves youth population, 17 and younger. These are short-term crisis stabilization programs that are located within residential neighborhoods. They are 6 beds. With no more than 6 individuals at any time. They are staffed 24/7 with trained clinicians who provide a program that is based off of a DBT skills program by Dr. Julie Brown. We have opportunities for individuals to work one-on-one with our staff as well as in group settings. We also have community outings where we integrate our individuals into community activities. Typically for our adults, the length of stay is anywhere from 15 to 30 days and may be extended if there's a clinical need. For our youth home, our stays are typically 8 to 15 days, but again, can also be extended due to clinical necessity. Next slide. Kara, I'll pass it back on to you.
Yep. So this is just a brief overview of the difference between mental health crisis and mental health emergency. One of the big questions that we get as mobile crisis providers is, how do we know when is a good time to call you? How do we know if you're the appropriate person to call, or do we need emergency services? And so one of the things that we like to talk about is the difference between a mental health emergency and a mental health crisis, and us being a crisis program, REACH being a crisis program. So when we see things like somebody actively engaged in a suicidal act or a homicidal act, perhaps they have a self-injury that needs medical attention, or they're actively under the influence or impaired by drugs, maybe experiencing psychosis, not able to make rational or safe decisions. These are more emergent scenarios that may require more attention than a crisis provider is able to provide in that moment. When we talk about crisis, somebody may be experiencing thoughts of harm. They may even have a plan. But one of the key things that we look for when we're talking about what is the best support for this person is their ability to commit to safety in that moment. So even if it's just for a few minutes until someone from my team or Leaf's team is able to get to them, are they willing to stay safe, to have a conversation? Or is there something more active and acute going on that needs support right now in this moment because it's not safe? So those are some of the things that we look for when we're determining if this is an appropriate level of support for somebody. And when it's not and more attention is needed, we're able to help coordinate with our other community providers to make sure that that person gets the level of support that they need. And in some circumstances, that is advising somebody that they should seek support from emergency services. And so here to talk to you this afternoon, we have emergency services. I'll pass it to them.
Hello, everyone. I'm Arnisha Moody. I'm the Client Services Entry Bureau Director, and I have a few people from Emergency Services with me today. I have Suzanne Schuler. She's an ES clinician, and she'll be presenting. I also have India Diggins, who's the Assistant Emergency Services Supervisor, and I have Andrea Tree. Andrea is our ES Divergent First clinician, and her primary role is working with children and adolescents. So I'm going to hand it over to Suzanne Schuler now, who will be presenting on emergency services.
Thank you, Arnisha. Hi, everyone. I'm Suzanne Schuler with Emergency Services. And so Emergency Services is a federally mandated program that it works 24/7, 7 days a week, 365 days a week. We never close. And we serve individuals that are experiencing a wide range of mental health emergencies, such as we do crisis interventions to de-escalate situations. We do assessments for voluntary hospital or involuntary hospitalization. We do referrals. When we do assessments for involuntary hospitalizations, we usually do that when all other less restrictive alternatives have been explored and they were not an option. So if like CR2 or REACH or parents or private provider, then we will explore a more restrictive alternative, which is an involuntary hospitalization. We also do consultation. We get calls from parents, from teachers, from anyone, hospital staff that just want to consult in cases, whether the person is in crisis, whether an emergency is happening and we need to step in, or other ways that they can handle the situation. And we do short-term supportive counseling. And we have follow-up. We work with certified peer specialists also to provide, I'm sorry, who's managing the slides? I'm so sorry. There you go. Sorry about that. So this is just a graph to show you more or less the statistics, the percentages for emergency services from 2018 all the way to 2021. As you can see, we have RTC, which means return to community, that we were able to safety plan or they did not meet criteria. And we have about 60% of the total contacts that we've had, which is 1,741. 60% of those were returned to the community, which is good news. We were able to refer them to the appropriate agencies. The family was cooperative. The person was willing to commit to safety. So that's good news. The next percentage, the 2%, is crisis stabilization unit that we can place people at Wellness Circle or Recovery International. And then if we have voluntary, which is, I cannot see very clearly there, but those are voluntary admissions. And then the top percentage is our DDOs. So 33% are our DDOs. We have the goal of achieving at least 80% of returning people back to the community. So that is what we are trying to do with less restrictive alternatives. Next slide, please. So emergency services, like I say, we provide assessments, we provide emergency interventions, we stabilize people that might be having a crisis or an emergency, And we collaborate with other regional partners such as CR2 and REACH. And we coordinate whatever the needed services and how can we help these youth and the family and the individuals who may have a developmental disability. We also offer brief and supportive counseling, just follow up. Again, is just to follow up, to continue to support the person until they can be connected to the right agency or support. We co-develop safety plan with the family, with private providers, with CR2 and REACH, and we do crisis interventions. We also have certified peer specialists who are a wonderful addition to our team. They help following up on people that we may have had contact with and they will return to the community, but we feel that they will benefit from, a phone call and a little follow-up, or to make sure that they followed up with whatever referral we made. So the peer specialists are wonderful. And of course, we facilitate voluntary and involuntary hospitalization. Next slide, please. No, one before. There you go. No. Huh. All right. I guess the next one. All right. Is there a cause for emergency services intervention? Yes, there is. Emergency services will bill Medicaid. It is a billable service. People that do not have insurance or have different other kinds of insurance, they will be billed according to the CSB, the Community Services Board sliding scale. Next slide, please. That's the one that I had before the other one. That's okay. So we can talk about this one. Who do we serve? Individuals experiencing a mental health emergency, acting on a suicidal threat, presenting as being in imminent danger. People that are homicidal and are not willing to commit to safety. They are making very overt, specific, targeted to a specific individual and threats to harm them. Also people that experience self-injurious behaviors and that they need medical attention. Sometimes they do harm to themselves that require medical attention, and if they don't want to do that voluntarily, we may have to step in. We also serve those that may be severely impaired by drug or alcohol, that to the point that they are not reality-based, they are putting themselves in a situation of risk that we may need to ensure their safety with a hospitalization or with whatever intervention we think is necessary. Sometimes people present with very erratic, very unpredictable and unusual behavior. Sometimes when the behavior is out of character, it can be a red flag. And then we also serve those what we call our third prong is the person's inability to care for themselves. And this we measure by assessing the person's judgment. Is the person able to engage in a reality-based dialogue about their current situation, their current needs? Are they understanding the consequences of their behaviors? Are they putting themselves in situation of risk due to a mental illness? People that have not eaten in multiple days, or people that are not bathing for multiple days, that are not in touch with reality. Those are the third prong individuals that we also help assess. All right, next slide, please. All right, emergency custody order, also known as an ECO. This could be issued by the magistrate. When we request that, it can also be initiated by the police based on the situation. We need to show that there is probable cause to believe that a person is at imminent risk of harming themselves or harming others. and that is due to a mental illness. We need to be able to prove that there is substantially inability to care for themselves, as I was saying earlier, putting themselves in situation of risk, continually to trespass at certain facilities or airports or buildings and incurring legal charges and such. Sometimes when the person is not willing to be hospitalized voluntarily, or if someone is unable to maintain choice, they are ambivalent. First they say yes and they say no, then we may need to proceed with our more restrictive level of intervention that will be the ECO. The purpose of an ECO is for further assessment and observation. We are able to see something is going on with this person, and we just need to assess and observe and see what's going on. Next slide, please. Oh, I have them in different order. Let me see. Yeah. Okay. So emergency custody order also, it's the person remains in police custody. The police are able to transfer custody to the hospital, but the person stays in custody under an ECO until we can issue the temporary detention order, also known as a TDO. And this ECO lapse, it only lasts 8 hours. During these 8 hours, the person needs to be assessed. We need to find a bed. We need to secure the bed before we get the TDO. And then if the ECO, if it has been more than 8 hours and the person either has not been located and they were unable to execute it, that ECO can be returned, must be returned to the magistrate as unexecuted. Once we get someone under an ECO, we must notify the state hospital. And this is to give them a heads up that this person, if we're not able to find a private bed somewhere, the person may come their way to the state facilities. We have 3 facilities. CCCA is for children 17 and under, and then 18 to 65, they go to Northern Virginia Mental Health Institute, and people over 65 go to Piedmont Geriatric. The ECO can result in an involuntary hospitalization. It can result in a voluntary, it can even result in a medical admission, or the person may be released to the community. Next slide, please. So the process of the TDO usually starts with an ECO. So we do the assessment to determine whether the youth meets criteria for involuntary. Again, this is after we have explored all other less restrictive alternatives. The youth will have to be transported to Virginia Hospital Center for medical clearance because they need to rule out that the current presentation may not be due to a medical or organic condition that has caused this. So then after we finish our assessment, we determine that they meet criteria. While they're being medically cleared, we need to complete a bed search, and we call all the hospitals in the Commonwealth. We cannot call for hospitals outside of Virginia. Once we have secured a bed, we ask sheriffs to serve the petition. We've completed a petition to the magistrate to give us a TDO. That petition needs to be served on the child and the parents, because that petition serves as a summons to let them know that there will be a civil commitment hearing to resolve what the next steps are. And then law enforcement will transport the youth to the accepting facility. Next slide, please. So the continuum of care, you can see that we start with less restrictive, right? We call the regional crisis center. They decide where this call needs to be sent, maybe a referral to an outpatient, maybe an emergency appointment with their providers. If not, maybe CR2 or REACH may need to step in and help. Once they do what they do, then they can assess the situation and say, no, we need a higher level of care. And that's when we come in and we do the hospitalization. Some hospitals, VHC, Inova, and also Dominion Hospital offers partial hospitalization programs. Less restrictive will be voluntary, of course, and the more restrictive will be involuntary hospitalizations, which is what we do. And the Code of Virginia Behavioral Health Code requires that we explore the less restrictive alternative first, always to ensure their safety, of course. And I don't know, I think that's it for me. Who's next?
This concludes our presentation. I think we're going to go to the question portion.
Yes, time for questions.
If we can hold just for one moment, I'm going to stop the recording. And while I'm doing that, I'd like to thank again our wonderful partners with the Department of Human Services Children's Behavioral Health Group. They co-sponsored this with us, and we're so grateful for them sharing all of their wisdom and knowledge. And a shout out to my colleague, Wendy Crawford, for helping us coordinate the session. Just one moment and we will pause. We'll stop the recording.